when I do a recommendation, use this method. I use the language that was outlined by the U.S. Preventive Service Task Force. With this language, just to stand the language between us, when I say that it's a grade E or D recommendation, you should offer or provide this service. If I say that is a grade C recommendation, I offer or provide this service only if other considerations support the offering or provide this service in an individual patient. Grade D, do not do this. And grade I, if the service is offered, tell the patient that's not enough evidence to support this. And saying this, I now go to the presentation and do this presentation like a newspaper style. Because evidence-based medicine is a dynamic tool that changes every day and changes by a human factor also. Sometimes who does the meta-analysis can write based on some bias and where they choose the papers to be included in meta-analysis. But and I stayed here the date because, as I said to you, sometimes new evidence appears tomorrow. So it's like a newspaper style. And skin incision. Skin incision is a grade C recommendation about favoring joint coil incision versus funny steel incision. And if you look at the data between joint coil incision versus funny steel incision, all of that favors joint coil incision. Talk about post-febrile morbidity, talk about pain, post-operative pain, talk about hospital stay. All of that recommend joint coil incision. But, as Professor Visser said tomorrow, not everything is about cure. Everything about care in medicine. And sometimes the patients don't want a little higher incision. Sometimes they want a lower incision. And we don't have any paper produced asking the patient what they would prefer. Because it's not possible to do RCT doing that. You have to choose one technique. So I think there's a grade C recommendation to do a joint coil incision. Then a funny incision, talk about skin incision, not talk about the operative technique. But if you do a funny steel incision, the patient asks, I want to use bikini, very low bikini, I live at Rio, I want to go to the beach every day, very, very, very low incision. If you do that, to dissect or not dissect the inferior rectus fascia, it's a great eye. To not dissect the inferior rectus fascia because it is only one trial showing that if you not dissect the inferior rectus sheath, you have less blood loss and you have less pain. It's just one trial, but favors not to dissect the inferior rectus fascia. During the funny steel, look here, the group B, this is a randomized control trial showing that you have less blood loss and less pain in the post-operative days if you don't do the dissection of the rectus fascia, the low dissection. But the bladder flap. Bladder flap is a grade D. Do not do the bladder flap. Why do not do the bladder flap? And I use today two studies, one with clinical aspects and other with some histologic aspects. Clinical aspects, these studies from the group from Maconis show that the only difference between bladder flap or no bladder flap in the two groups on the RCT is the incision to delivery time. You gain 1 minute not to doing the bladder flap. And you have no difference between blood injury, microhematuria, pain score, endometritis, or days post-dialysis. No difference. But this don't address the problem of adhesions. If you do a bladder flap, bladder flap appears to have more adhesions. And this is one papers, one of the most beautiful papers that I have already read about a surgical method. Because these papers, and the authors are here, and on this paper they divide on two groups. One group, they do a bladder flap, and another group, they don't do a bladder flap. It was a randomized controlled trial, and after they do a bladder flap, and the patient was in a second pregnancy, in a second C-section, they do biopsies on the uterine scar and analyze the histologic aspects of these biopsies. And the most beautiful thing about this paper is the method that it was conducted, because they isolated all the aspects that could cause pelvic adhesions in the surgeries. Like you have to do the same method in all these patients, and you don't use toils and other things that could cause adhesion. So I think the method of this study was very beautiful. And look the results over here. If you do the bladder flap, you double the risk of head adhesions, fibrosis, and angiogenesis. So I think that you don't have to do bladder flap. But if you can contain yourself, and yeah, I want to do because I like my finger put down the bladder. If you cannot contain yourself, because it's nice to look, I feel more comfortable.
Only was the first. After it's too different.
But if you cannot contain yourself, do not close the visceral periton. Do not close it. Here, another RCT showing that the symptoms of frequency, or urinary frequency, urinary leakage, and urinary eligible to physical activity occurs more in the group that you do the visceral periton closure against the group that you don't do the visceral peritoneal closure. And this is have significant meaning. So, but after 6 months, you don't have these symptoms. But do not close, because you don't mean anything to the woman to close the visceral peritoneum. And this is an ultrasound, I will not lose time on that. But sometimes it's more important to do the right question than find the answer. And not to do the bladder flapper, I know that, but it's not a question to do or not to do. I think the right question is, in some cases, we have to do, and I would like to address this question to Professor Marcus Type, and we can discuss after. In that case, that we are called to do a C-section, an emergency C-section, on a patient that is on the second stage of labor. And the head is too low. And it's that case that you should be doing a forceps or a vacuum delivery, but you don't feel comfortable to do it. You should be doing that, but the head is too low. To do this bladder flap on these cases would help to reach the baby. I feel so, but I would like to hear your opinion after. Uterine closure. Single layer. To do a single layer is a great aid of evidence. And why I'm saying that? And it's not, here's the right question also, is how to do this single layer. See, this is a very beautiful meta-analysis comparing locked suture for single layer against unlocked suture and against double closure. If you lock your suture in a single layer compared to double layer, favors double layer, talking about risk of uterine rupture. Okay? But if you do a single layer closure without locking your locking your suture, it seems to favors it against double layer. But it's not, it don't have a significant meaning, because here it is cross the one. But seems to. And I think that, and I talked this yesterday, because when you do hemostatic sutures, very hemostatic sutures, and you do alarm to the wounds. Okay, I'm not finding the answer right now in English, but you don't help the body to heal himself, because blood is life. So if you cannot help the blood to reach the wound, sometimes the scar, you produce a weak scar. And sometimes we are anxious because you do the suture of the uterus, and sometimes you have a small bleeding on the side of the surgery, and keep suturing. And some insight of reading this paper is now, in this case, maybe you can using some fibrin sealants instead of doing sutures to help to not use so much hemostatic techniques. Is an insight thing that we could also address later on the discussion. But this meta-analysis was produced on 2011, and you moved for the same group doing another meta-analysis with some other authors in 2014, comparing single layer versus double layer without the lock or no lock feature. And see that all the clinical features comparing single layer as double layer, and I'm talking now about maternal infectious morbidity, endometritis, wound infection, and blood transfusion. All of them do not have a difference between the groups. Even the mean blood loss or the hospital days. The only difference is the time of C-section. Okay, and this is very easy to understand. You gain 6 minutes not to do double layers. You gain 6 minutes doing a single layer in the middle. And talking about uterine rupture, you don't. It seems to add some risk doing some single layer, but you don't have a statistic meaning because you don't have a good p-value. And the only difference between single layer and double layer is the lower uterine segments, talking about the thickness of it measured by ultrasound. You have 2 millimeters difference between single layer and double layer, but this difference don't translate to a clinical meaning. Now, this moving from Canada to now I'm moving to Sweden, and this I think that this is the largest cohort, prospective cohort, published analyzing, addressing this question. They take almost 20,000 patients, they follow up, and from these almost 20,000 patients, 7,500 of them enter a trial of labor. And they have 2,500 with 1 layer closure, and 5,000 patients with 2 layer closure. And the uterine rupture occurred in 38 patients of these 2,500 and 65 patients of these 5,000 patients with double layer closure. So now let's see the results. Don't have any difference between doing a 1 layer closure or 2 layer closure. The risk that they found to have a uterine rupture in trial of labor, they found it to happens more in patients that have more than 35 years, have a maternal weight below 160 centimeters, maybe the baby is too large for the small patient, okay, and the baby is large for the gestational age, the risk, or the patient have infection with the trial of labor. So this is the clinical risks found in this prospective cohort, and not single layer versus double layer, the same risk. So to do a single layer is a grade A of a recommendation. And peritoneum, not to close it, a grade A, not close the peritoneum, the parietal peritoneum, not close it, a grade A. And I will defend myself now because make a break now, just to speak. I think that everybody, one day, you'll find the Creator. Everybody. And the Creator, that may be God, they may be Allah, maybe Buddha, maybe Oshosi, or maybe Tupã. Tupã is a Brazilian Indian god. Maybe Tupã. I don't know yet. But I want this to take a long time because I want to meet you in 20 more birth meetings. But this want this to take a long time to happen. But when it happened, you asked me, Eduardo, why you not close the peritoneum? I made it close. Why you left it open in your surgeries? Why you against me? I want to know. Yes. And my view said to me, why you made it close? I said, I made it open. Why you close? And I said, oh, look this data. Look this data. I talk to God. If you not close the peritoneum, you have less operating time, you got less postoperative days, and you have less chronic pain. And talk about adhesions, I don't see some difference. This is some Cochrane data. And God may say, okay, this is your data, I have other data. And this is the problem for the evidence-based medicine. You can find that. A systematic review for everything, showing your point. And this, I have the data from my Chinese friends here, and they show that if you do not close the peritoneum, you have almost 5 times more risk to have adhesion in this meta-analysis. But look the characteristics of this meta-analysis. I say, God, okay, God, I'm surprised by that, but see that all these papers are in Chinese, okay, and I could not understand how do they do almost all these patients, almost all these works are in Chinese. Have one work here that's not Chinese, but I read this work, and when I read this paper of Hamill, 2007, it was not a RCT, it was a retrospective study. And it was also included in a meta-analysis, a retrospective study. And some papers are RCT, some papers, and I could not find a clear method on these papers. And maybe it worked for Chinese people, okay? But I don't know for me. I cannot use this meta-analysis on my patients because it's not clear the method of how do they perform the operations. I cannot understand the method. It's not the same method. And to compare something, you have to compare the same way to do the things, I think. So, okay. And more, I talk to him, more, see that if I'm not closure the peritoneum in my country, you have 3 million deliveries in 1 year, and 55% of C-sections, more than 1 million C-sections. And if I use Category 1 to close the peritoneum, I will spend R$2.50, and Vicryl, I use R$8, or if I want to use Vicryl, I will spend R$8. And if I don't closure, I will do a net savings of more than R$6 million in 1 year. I'm not talking about time. I could save more than almost 20 years of time, surgical time, not closing the peritoneum. So I do a good for my health system. Okay, and I will ask him, now I can enter the paradise, and if he responds no, you will go to the purgatory because you have done too many C-sections. Okay, and now I will finish with the skin closure. The staples against suture is a great C to offer sutures. And why is a great C recommendation? Because a very beautiful randomized controlled trial, a multicentric randomized controlled trial, show that if you suture the patient against staples, you have less wound complications. Talking about separation of the wound, okay? But these studies do not care for the cosmetic aspects. And not everything is about cure, sometimes about care. So let's ask the patients, your opinion. And this is a very interesting study comparing the same patients. In half of these patients, half of the wound in the same patient, they use staples, and half they suture. And after they ask the patient, which side do you prefer? After some months. And the patients prefer the staple side, the cosmetic aspect of the staple sides after 6 months. And not only the patients, it seems that some plastic surgeon also prefers the side with the staples. So, if you want less wound complications, do sutures. If you want a cosmetic view, okay, you can offer the staples to your patient. And I think that I end my talk today. Thank you.
What about intercutaneous?
Eduardo, thank you.
It was Cesarean.
So, but God says you, after the birth congress, you should put the C-section rate in your hospital down.
It's going down right now.
So thank you, Eduardo. We are going to discuss later on, and I would like to invite you.
Yes, my friend. I know I was in presentation.
But we are going to give the prize this section.
Maybe we have time for a couple of questions after the first two presentations, since Jose is preparing his presentation. There is any question or request to Michael Stark and to Leonardo Cordioli? You are satisfied by the presentation, or a little bit sleepy because of the time after lunch? Huh? Gusto, can I have the microphone? Excuse me. Microphone.
One question for Dr. Stark. I do not really know if it's better to externalize the uterus, you perform the uterine suture, because you can see the ovaries leaving the uterus in the abdominal cavity when you clean up the blood that becomes very good. And does it not increase the risk of infection, or does it not increase the pain after surgery? I myself never take out the
Okay. Number one, I nearly finished my presentation, and it took me a note 1 minute, so I didn't speak. I do not clean the blood. I just take the cloth with my hand and I leave fluid blood inside. The reason is, do you remember that many years ago, babies with RH problems, we used to do abdominal transfusion. And in 1 or 2 hours, it's absorbed back. So you don't have, on the contrary, if you leave blood inside, you get less decrease of your hemoglobin. Number one. Number two, of course, you can look and see infection, no more infection. We did the study, we studied it, no more infection if you take it out. But of course you can look, but sometimes you see just the pole of the ovary and you believe that it's okay. And so it's very important. But the most important is that if you take the uterus out, and you could see it also in the Swedish study, you take the uterus out, you get less bleeding because you can contract the uterus with your fingers. That's the main reason.
Neither of you mentioned. Neither of you mentioned the Coronas trial. Was there a reason for that? The Coronas trial, is it? It was a big trial on
For closure.
for different aspects of cesarean section.
For different.
use the microphone.
Yes.
I mean, I'm surprised you didn't mention it. It's one of the most read papers, as far as I saw, on the BJO.
I try to use the most recent literature trial. The Coronas trial, I know that's my reference, but the Coronas trial is the what aspect?
Well, the different aspects. I just wondered why it wasn't mentioned.
Why I didn't mention it? Well, I used to put on my presentation, I was as a guide the last revision of the Bergella and also the co-workers, and the name is?
I can't remember the first author. Have you read the Corona? Yeah, it's various.
Peter Brocklehurst.
Peter
Brocklehurst.
That's right.
And well, this is a difficult question. Why I didn't use it? Because I follow the time 20 minutes.
Okay.
And I follow. Why? I didn't use it.
No, wait a minute, we discuss later. So it's better to go ahead now. Jose is ready. We have first of the two presentations is this section. So we move forward with prevention postpartum hemorrhage during cesarean delivery by Jose Palazzi.